All right, welcome everybody to this edition of AJOT Authors and Issues, where we talk to researchers about their work and other things to help bridge the gap between research and practice. My name is Stacy Reynolds. I am the editor-in-chief of AJOT, and joining us today is Sabrina Hinckley, who is our new AJOT student representative. She's taking the place of Isaiah Wills, who is out on field work. So go, Isaiah. Our guests today are Dr. Bobbi Pineda from the Chan Division of Occupational Sciences and Occupational Therapy at the University of Southern California, Molly Grabill from St. Louis Children's Hospital in St. Louis, Missouri, and Carolyn Ibrahim from Rush University in Chicago, Illinois. They are the authors of an article just published in AJOT entitled "The Prevalence of Early Feeding Alterations in Preterm Infants and Their Relationship to Early Neurobehavior." That's a lot of big words. I'm hoping you guys break that down for us today. But we're so excited to have you. And I'm hoping you can just start us off by telling us a little bit about yourself, where you're zooming in from, and how did you guys all start working together? Because you are now in all different parts of the world, of the country. So how did this all come about?
Well, I can start. My name is Molly, and I am from Michigan originally, but live in St. Louis, Missouri. I was a part of Dr. Pineda's NICU research lab when I was in graduate school at Washington University. So got to know Dr. Pineda and fell in love with her work with preterm infants.
Great. Carolyn, how about you?
Yeah, so like you said, I'm in a PhD program at Rush University, but it's a virtual program. So I live in Santa Barbara. And within the program, I'm a visiting student at Dr. Pineda's current lab at USC. So I live in Santa Barbara. I work in the NICU here. I'm part-time. Then I'm a part-time student for my PhD working with Dr. Pineda's lab.
Wow, that's amazing. And Bobbi, tell us about you and your amazing lab that you run.
So I'm Bobbi Pineda, and I run the NICU therapy lab. It originated at Washington University, where I was for 14 years. But 3 years ago, I moved to University of Southern California. So I've been able to meet students, at Washington University, which is where Molly Grabill did her great work. And now at University of Southern California, we have Carolyn Ibrahim in our lab. So I've been able to work with her as well. But, our lab largely looking at modifiable factors that can improve neurodevelopmental outcomes. And so students come through the lab and they're able to choose their own project and really, do it from idea conception all the way to the end. So it's really been fun to, engage in this journey with students that come through.
That's great. Yeah, I love that. Well, this paper is very specific to feeding and feeding outcomes, and specifically looking at children who were born very preterm. So, for everybody listening, I was hoping you could get us on the same page and tell us what that term very preterm means, and what are some of the common behaviors or neurobehaviors that are seen in children born this early?
So for the purposes of our study, we quantified very preterm infants as those that were born less than or equal to 32 weeks gestational age. So there's different levels, but that's the marker that we use to quantify this. And as far as neurobehaviors, we see in these preterm infants alterations in their tone, whether that's higher tone, lower tone. We see different abnormal reflex patterns, varying levels and ability to regulate their state of arousal. Stress is a big factor in the NICU, and that obviously affects their ability to feed and to be successful with feeding.
And when you talk about stress, how does that manifest? Like arousal regulation challenges. Do you see that physiologically too? That they're showing signs of physiological stress?
Yeah, absolutely. If you think of our, a typical NICU environment, these babies are exposed to kind of this unprotected environment outside of the womb, where there's, alarms, and they're being poked and prodded. They're having their vitals checked. They're outside, and we can help to regulate their temperature and all of that. But think about all of those stressful experiences for someone who is not fully developed yet. And so we see that in terms of their stress responses, physiologically too, in terms of their heart rate, their blood pressure, their oxygen levels, their cries, their cortisol levels, all of these different factors we can see in terms of their stress.
So just going off of that, as a preterm infant, your physiologic stability is needed first before you can kind of build up from there in terms of your ability to have stability within other systems like motor, state, attention, things like that. And so almost all, especially very preterm infants, they're working on that physiologic part first when they're born. And so that's developing while they're in the NICU, versus a full-term infant typically comes out, if they're healthy, comes out with that physiologic stability already at play. And so they can be, working more on state, motor, attention, things like that. So we're starting all the way back, kind of at the very basics with the very preterm infants.
And just to build on that, when we look at preterm infants, we talk about the estimated gestational age, which is really a marker of how early they were born. So when we talk about an infant at 32 weeks gestation, it means that they were 8 weeks early, based on a normal gestation being 40 weeks. The other term that we oftentimes use is postmenstrual age. So this is really the estimated gestational age, how early they were, plus the number of weeks that have elapsed since the time of their birth. And this marker of postmenstrual age is really important because it tells us really where the infant is along the developmental trajectory. And so the earlier that you're born, your brain is still immature until you get closer to term equivalent age. And, to Carolyn's point, the baby does have to gain their physiological stability. But some of the other things that we want to see along this trajectory from preterm birth to term equivalent age is increasing their arousal. And so many times when you're born very early, you'll be very, very sleepy and not be able to wake up for long periods of time. And then from a motor standpoint, you'll lay in more extended postures. And so like if you're at term equivalent age, there's this physiological flexion that kind of happens automatically, like that's generated from the brain basically. And so we want to see our preterm infants kind of go through this trajectory where they go from being sleepy to then being able to wake for longer periods of time in order to be able to orally feed. And then also to pull in their tone and their reflexes that are emerging during this time frame. And all of those factors kind of put together then allows the baby to be able to orally feed closer to term as their brain matures. But if you try and do it too early, there's just not enough arousal and reflexes and tone and physiological stability in order for them to be able to master it.
Yeah, that makes sense. Sabrina, you want to jump in?
Yeah, of course. Hi, everyone. I really found this article really interesting because after my time at VC and once I'm in the field, I hope to pursue a career in the NICU or the PICU. I've always loved peds and loved the inpatient care. So I thought this was a really awesome article to read. So I was hoping if you could kind of tell us more about why independent oral feeding is such a major criterion for discharge from the NICU and why it can be so challenging for some preterm infants to achieve. I know you kind of touched on that a little bit with what you guys were just talking about, but I was wondering if you could maybe go into a little more detail with that.
Sure. So when babies are being discharged from the NICU, we have to be confident that they're going to be able to survive and thrive at home. And so a major piece of that is being able to take in adequate calories to continue growing. Ideally, that would be done through oral feeding. And so that is the primary goal. And so practice differs in different places, but typically assuming that so if the assumption is that the infant will be able to achieve full oral feeding by the time of discharge, they're typically in the hospital until they do that. And different hospitals have different criteria, but they just want to see that the babe is taking in what they need to, and then is demonstrating some consistent weight gain for maybe 2 or 3 days before they're comfortable letting them go home. Can you repeat part 2 of that?
Yeah, of course. Sorry, this is a 2-part question. Just why is it so challenging for some preterm infants to achieve this feeding?
Yeah. So kind of going back to what Dr. Pineda was saying, there's a lot of things that need to like kind of come in and work together for the infant to be successful. So we're waiting, I mean, we're helping facilitate it along the way, but we're also waiting for the development of, you know, the ability to arouse consistently to eat. So a baby initially may only truly wake up 2 times a day, and that's not going to be enough to eat enough to sustain their weight. So we need them to be able to consistently wake up, you know, often almost like every 3 hours, and then stay awake to eat their, you know, calories before they fall back asleep. So you're waiting for that, as well as the ability to kind of orient to midline, organize around what's going on, coordinate the suck, swallow, breathe to be able to, you know, actually eat food. There's just a lot of variety of factors that are in play that preterm birth just poses an added challenge too for the infants.
Okay. Very cool. And then kind of another question to kind of follow up on that. I was wondering, when it comes to the decision-making process behind whether the NICU team will continue to work on independent oral feeding, or if they'll like discharge with the G tube or NG tubes, like kind of how they decide which path to pursue with treatment for infants.
Molly, do you want to
I
go?
want to talk about decisions to go home on a G or not.
I'm not currently working in the NICU, and I think that's probably a multidisciplinary decision, right? Medical team and dietary team, taking into consideration what the parents are going to be comfortable with, and how their progression is going. Is this what decision is going to be best for this particular baby and this particular family?
And I think Molly's correct that it really depends. It depends on a lot of factors. There's multidisciplinary input, but I think the other thing that's just notable is that process that they use to decide G-tube versus NG varies from NICU to NICU across the United States. And some may be a little bit more conservative in doing G-tubes, and then others might be a little bit more proactive. I think it's generally well accepted that you don't do a G-tube before that term equivalent age, so that you give the baby a chance to actually show their colors and be able to succeed. And most will even push it out like another 2 weeks. So like the decision won't be made until at least 42 weeks post-menstrual age, or 2 weeks after their birth date, or their due date, sorry. But the other thing that just seems to be happening more and more is NG tubes. So, G-tube being the permanent solution to not being able to take all nutrients in by mouth, and then NG being more of like a temporary solution. And I think even if you looked like 10 or 20 years ago, there were hardly any hospitals that would send babies home on NG feeds. And now it seems like there's a little bit more acceptance of that, when it just looks like the infant just needs a little bit more time. Like they're making progress, but they just need a little bit more time. But again, that would really vary from hospital to hospital.
And that also varies on what services are available outpatient. So if the family has come like a long way to a major medical center and their home is kind of a little bit more isolated, you might be less likely to discharge them home with an NG tube unless parents are trained in being able to replace it. because they can come out fairly frequently. Whereas if you live, a mile away from your hospital, and a trip over to the ED to get it replaced is no problem, and there's, feeding therapy available in the community, and parents are able to be home with the baby all day. There's a lot of factors in that regard too, about how much support there will be for the baby when they discharge, to make sure that things continue to be safe, but that also the baby has access to continued services to facilitate the end piece of that transition. The other factor that I would say on the inpatient side, in terms of helping to decide if an alternate means of nutrition is going to be needed, would be the presence or absence of any other major comorbid conditions. So there are a lot of conditions that are more common in very preterm infants. For example, if a baby had a bleed in their brain, particularly like a more severe one, that might be a baby where, in conjunction, between the very premature, being very preterm, and the brain bleed, you are more likely to maybe recommend the more long-term solution of a G-tube if they're not really close to full oral feeding by that term equivalent age standpoint. So you're taking in kind of all other associated conditions that the babe has as well as looking at kind of what their trajectory has been up until that term equivalent age.
That's great. It's such a complex thing, and there's no way to just, I get that there's no easy answer to that question, but I think you guys did a great job explaining all the different factors. Switching gears a little bit, in this study, you used the neonatal eating outcome assessment, and you also used the NICU network neurobehavioral scale. So these were two of your outcome measures. So I was curious about why you chose these measures and whether these are typically used in NICU settings. Would clinicians listening to this podcast know about these? Are they ones they should know about? And how did you pick these tools?
That might be a good one for me to answer. So this was part of an overarching study, really looking at the trajectory of oral feeding in these preterm infants. And within our lab, we typically, early on when we first started doing research, we used the neonatal oral motor assessment scale. It's a tool that was developed by Marjorie Meyer Palmer. It's largely motor-based, where you look at jaw and tongue control in the first 2 minutes of oral feeding. And what we found is that we really wanted something that was a little bit more comprehensive. So one that would look beyond just motor, two, that would also correct for the postmenstrual age of the baby. So like if you do the NOMOS, for example, you're just looking statically at how the baby performs in relationship to what you would expect for a full-term infant. But, if you're a pretty sleepy baby and you're being fed at 34 weeks, that sleepiness is normal for your postmenstrual age. And so we actually developed the neonatal eating outcome assessment in our lab based on that. So we went through a whole process of, systematically developing it and then testing psychometrics. And it really helps us because, again, it puts feeding in relationship to what the expected performance at that postmenstrual age is. So that's why we chose that one. And then the NICU Network Neurobehavioral Scale is a 115-item comprehensive assessment. And I think one of the things that I love about it is that, as OTs, we want all the information. Like there's so many different kind of pieces of functional outcome or how babies participate in or engage in activities. And so the scale actually has 13 different summary scores. And so it kind of like goes the gamut. So looking at habituation and tone and reflexes and self-regulation and how excitable they are, how they exhibit stress signs during the assessment. Are they lethargic? And so I think having like all of these different subscales is just something that I, as an OT that wants to, kind of take a pretty holistic approach to the assessment, was wonderful. The other thing is like the timing of when the assessment is done is a big factor. So in this specific cohort, we were looking at term equivalent age. And so at term equivalent age, the babies can tolerate the significant handling for the ends. But for example, if we were doing the assessment on infants at 32 weeks postmenstrual age, or who were still intubated, this would not be the tool for that. So it suited our needs to be able to take that comprehensive look at neurobehavior in relationship to feeding.
It's great. Thank you. Yeah. And I like that philosophy of like, if it doesn't exist, I'm just going to develop it myself. And now you can use it whenever you want to.
So one of your key findings was that feeding problems were very common. I think in the article it said around 80% of your sample. So it's very common for preterm infants, even when they reach term age, and that abnormal muscle tone and reflexes, like you've been saying, were related to their feeding performance. Did these results surprise you at all, or were there other factors that you expected to kind of emerge from your study?
Yeah, I think I was not surprised that both of these subtests or sub-items, the reflexes and the hypotonia, that they do contribute to feeding performance. Just knowing what we know about those things, you know, in terms of your whole body, your reflexes control so much of your movement, of your arousal, of your attention, of your participation, and your tone globally would make sense to contribute to feeding, as low oral motor tone can really have an effect on feeding. I think it's interesting that arousal was somewhat of a trending factor, but not yet significant. And so, you know, you've heard us talk quite a bit about arousal and being able to maintain awakeness for long enough to feed. So I think, you know, given more research, that might be something to tap into as well.
I think I was a little bit surprised at the significant number of infants that demonstrated either feeding challenges or questionable feeding behaviors, because it really, the literature shows that preterm infants do have challenges with feeding, but not quite that high. And I think it also just points to the fact that many infants are able to achieve full oral feeding by the time that they get discharged, but they're still showing alterations within the feeding process itself that warrant occupational therapy interventions. Sometimes we make the assumption that, oh, they're feeding, so they're good. But there's more nuances to the feeding process that, again, can warrant intervention. So that was one of my things that I guess I was a little bit surprised about.
And that kind of leads into my question, the next question being, given how many of these preterm infants had abnormal feeding patterns or diminished performance in feeding, what are the referral patterns like? Should it be that all preterm infants are automatically getting a referral to a multidisciplinary feeding team, or to occupational therapy more specifically? Like, is this a standard of practice everywhere, or do you feel like there are gaps in some places for children and families? Bobbi, you're smiling. I feel like that was a loaded question that I just asked. Who's going to take it? Carolyn, you have thoughts on that?
There's definitely gaps. So in terms of like early intervention itself, that program it can vary by state in terms of what diagnoses qualify an infant for the state-run early intervention program specifically. In many states, feeding therapy is available through early intervention, just based on the experience or expertise of the early intervention therapists that are seeing the infants. However, in other places, you know, not even state specific, but maybe just region specific, it may not be available through the early intervention program. Again, just based on what the expertise of the early intervention clinicians is. And so in that case, you would then be also looking for an outpatient therapy place that provides feeding therapy. So to give you an example, where I am, my hospital, like I am the only outpatient feeding therapist in the area. And I have one day on Fridays, because most of our early intervention programs don't offer feeding therapy based on the expertise of the clinicians that are in early intervention here. Whereas other places, I used to work in Illinois, completely different. Most of the therapists in early intervention have feeding experience, and the baby can get it just through their early intervention provider. So it just varies drastically. I would like to think that most hospitals discharging a patient who need feeding therapy would have something available outpatient through their hospital, but again, that's not. It varies everywhere. Everybody has kind of figured out their own system to try to get the babies what they need, ideally in a timely manner. And it just depends on kind of what your state provides, what your hospital provides, things like that.
And then just to add to that, I do think that there's value in doing a standardized assessment before the baby leaves to really define whether early therapy services are needed. I think that the timing in the neonatal period, like at term equivalent age, it can be deceiving because feeding is very reflex based. And so many times if the infant can root and suck and swallow, they'll be succeeding with the process. But one of the other big important things for early intervention therapist or early intervention referral is that there's a huge feeding transition that happens between 2 and 6 months of age. And so the reflexes are integrated, and so feeding becomes more voluntary. And if the infant has had negative feeding experiences, they many times will then choose not to eat, rather than reflexes kind of driving the process. And then the other part is there's huge anatomical changes that happen. And so the infant becomes more at risk of aspiration. And so having an occupational therapist that's involved in that, that transitional period is really key to continued feeding success, even after they're successful at NICU discharge.
So this is kind of, I guess, one of the last questions that I have. What advice do you have for occupational therapists and future occupational therapists like myself interested in working in the NICU with children who have feeding difficulties?
I would say working in the NICU with infants with feeding difficulties is probably your advanced level of practice. And so building your foundational skills, both with working with fragile infants, even in acute care, maybe before they're preterm, and just having your background understanding of development and, all of those kind of pieces that go into it, as well as your kind of baseline education in feeding therapy so that you can kind of marry those two. Rarely would you go from, your fresh, you have your master's or your doctoral degree and jump into being a feeding therapist in the NICU. It's not impossible. It's not impossible, especially if you have really good mentorship, but it's probably not super likely. For example, even myself, when I graduated OT school, I worked in early intervention and outpatient pediatrics as like my full-time job. And then I did per diem in acute care. So I was getting some really good, just baseline, development, kind of developmental challenges across the pediatric lifespan, seeing, a lot of babies who had previously been preterm and what it looked like at 2, 3, 4 years old. And that kind of thing, while also kind of keeping my skills sharp in the acute care population in terms of, lines and drains and like acute care specific things. And then was able to kind of marry the two, doing pediatric and NICU acute care. So that's not the way you have to go. It's not actually the way I intended to go. It's just the jobs that I got. But I do feel like they both really helped me. And then I could kind of put the two experiences together. But I didn't have a ton of mentorship available in my acute care pediatric experience. So if you're at a bigger hospital that has a lot of mentorship, you can kind of come in a little bit greener because you have good support around you to help you build the skill set.
And can I just add to that as well? I think it is a challenge. Like, I think maybe just calling it as it is, like for new therapists, because it is an advanced area of practice on top of an advanced area of practice. But to Carolyn's point, just building your foundational knowledge and then just trying to get your foot in the door at any point in time where you can start to build your clinical observations. And when I think of some of like the core knowledge that are important, I think in today's NICU world, it's knowing about infant-driven feeding or cue-based feeding, because that's one of the strong models. Like we've kind of gone from more of a volume-based feeding protocol to really being able to read the infant's cues and allowing the baby to lead the process, which has been shown to have better feeding outcomes. So learning anything that you can about that. I know there's courses on infant-driven feeding and then also on SOFI. Erin Ross teaches that. And then also, one thing that wasn't available for me when I started practice 30-something years ago is that there are just tons and tons of webinars to kind of introduce you to different topics. And many of them are done by like companies. So like Anara, Dr. Brown's, Medela, Dandelion, but they put on routine webinars where you can learn about something for an hour and they're free. They're on their website. So just encourage you to start just to engage in that as much as you possibly can. And then finally, I think it's also a really important thing for somebody who's interested in working in feeding to learn as much as they can about breastfeeding, because breastfeeding is the recommended mode of oral feeding for high-risk infants. And it's just another layer of knowledge that we really need to be able to empower parents to be successful with the process.
And what's next for this line of research? I mean, Bobbi, you've got a lab. I feel like you probably have a master plan, but this question could be for any of you of like, what are the next steps? And if there are people who are interested in doing work in this area, what are questions that need to be answered?
Oh, Carolyn, you should take that one and talk about your PhD work.
Carolyn, what are you doing for your PhD?
Yeah, so right now, so my long-term goal for my PhD work is to be able to create a comprehensive intervention program, ideally administered by the parents or familial caregivers, for oral motor skill development to help facilitate the transition from tube feed to orally feeding in very preterm infants. So right now I'm mostly kind of embedded in the literature. I did an integrative review of what oral motor interventions are currently being used and studied in practice. And now I'm working through some focus group interviews with clinicians who are providing oral motor interventions to very preterm infants in the NICU, just to try to get both an idea of what the research says, but also an idea of what's actually happening. And then looking at the kind of trajectory of oral motor skill development across postmenstrual age, to help us kind of figure out when different interventions might be appropriate for the infant, at various ability levels and postmenstrual age levels. So that's kind of where I'm going with my dissertation within Bobbi's lab. And yeah, we're in the beginning stages, but we're hoping we'll get there one day.
And then one other larger project that we have going on right now is we do have an NIH R44, which is a small business and innovation research grant. The goal of this is really to test a new bottle system that we developed that helps with pacing the infant, because infants like can suck, swallow, but they can't quite coordinate the breathing part of it until they're more mature. So the bottle actually allows the caregiver to pace the baby to stop the flow of milk. So we're testing that with a sample of 100 infants. And that project will expand our knowledge beyond just testing of the bottle to allow us to understand feeding across time as well. So we'll also be able to replicate these findings, hopefully, from this study in a larger sample of 100 infants.
I love it. I'm such a research geek. I'm like, that's so cool. No, I love it. That's so, and Carolyn, I really like, it sounds like one of the things you're looking at is that almost the clinical reasoning process behind progression. You know, these kids change so much, probably day to day, but definitely week to week. And to know what to do when and how to progress, I think is really important and probably essential for this population. So good luck with all of that important work.
Thank you.
So on authors and issues, we like to wrap up our discussions by playing a party game. So we're going to ask all of you today to, since our talk today was about feeding, I decided our game today would be about food. So we're going to play a shortened version of 20 questions where I'm going to give you each rapid fire 5 questions. So you have to, I'm going to ask the question and we're going to go in my order. We're going to go Carolyn, Molly, Bobbi. You're all going to answer, if you feel comfortable, a food related question. You guys up for this?
Right.
Yep.
Okay. So your first question is, what is one food that you hated as a kid that you really like now?
Brussels sprouts.
I was also going to say Brussels sprouts.
Me too. That's hilarious.
It's because the Brussels sprouts we used to have were like these mushy
And they were
things. And now,
steamed. Yes, they were like boiled to.
yes,
yeah.
they were like mushy boiled cabbages. Yes, I love that. All right, here's the next one. What is one food or drink that is always in your refrigerator?
Berries.
Orange juice.
Soy milk.
Okay. What kind of berries? I need more specific.
Blueberries are the preferred in my house, but we
All right.
we usually have a pretty hefty stock of all berries.
Yeah, we're berry fans.
Yeah.
All right, question 3. You guys are good at this. Name one food that is meaningful to your family or part of your family traditions.
We call them Carini cupcakes. It's my mom's maiden name. And basically any birthday party for any cousin on that side of the family had Carini cupcakes. And the special thing about them is that the frosting is pink. It's a homemade buttercream frosting that you put some of the juice that's in like the maraschino cherry jar. You pour that in when you're making frosting to make it pink.
I love it. Molly,
My family is largely of Dutch heritage, and so my grandma always makes Dutch pig in the blankets. So not the hot dogs with crescent rolls, but like pastry and the sausage in the middle. And so those are pretty famous around our household.
And for me, it's smoked ribs because it seems like whenever we have like large family gatherings, that's what we do is we smoke ribs.
oh, wow. Okay, I like it. All very good choices. Okay, we're on question 4. Name one food or drink that you absolutely avoid.
Soda.
Okay.
Mushrooms.
Love mushrooms. Bobbi, what's yours?
I don't know. I'm sorry. I don't know if I avoid anything. Yeah.
You don't have
Equal
one dreaded.
opportunity eater.
What's that?
That you're an equal opportunity eater.
Yeah, definitely. Yeah, I don't know if I avoid anything.
Fair enough. All right. You just avoid mushy Brussels sprouts, right?
Right.
Yes, definitely. Brussels sprout juice.
Yeah.
No, spicy.
What?
I feel like, don't you avoid spicy or you like spicy?
Oh yeah, I do avoid spicy stuff. But what drink would be
Oh,
Spicy.
well, it was food or
It was
drink.
food or drink.
Oh, got it. Yeah, I do avoid spicy food, especially like very peppery stuff. Yeah.
All right, last question. It's a hot summer day. You're going to the beach. What are you packing in your cooler?
Oh, watermelon.
Probably some version of sparkling water, LaCroix or otherwise.
Okay.
And for me, it would be like fresh fruit, like strawberries.
Very refreshing. All right. Well, thank you guys for playing our game. I feel like we got to know you on a whole different level beyond your research by playing. So, before we wrap up finally, is there anything else that you would like listeners to know about the work you're doing or resources that you would recommend? I know you already mentioned some learning opportunities. Anything else that you want to share before we log off?
I've got something. I think this research really kind of helps highlight that so much of what we do, as Bobbi was referencing earlier, is looking at the whole picture, looking at the whole infant. So it's easy. I think it's easy to be like, oh, they have feeding issues, let me work on feeding. But, you know, they have feeding issues, let me work on posture. They have feeding issues, let me work on, you know, orientation to midline. They have, like, there's just so much more that, you know, obviously through assessment of the individual infant that we as occupational therapists, I think, can see and address beyond just the aerodigestive system, which is obviously, you know, involved in feeding. But I think we kind of uniquely have a very holistic view, and it's important to keep that and maintain that even when the infant comes to you for feeding.
Very wise. Anything else, Bobbi or Molly, that you guys want to add?
That's really well said.
That was well said. Thank you, Carolyn.
Great. Well, thank you guys so much for being here today. We really appreciate your insight and helping us to translate this work to everyday practice, which is the goal of these discussions. And just a reminder that this is an article that's going to be published in the upcoming issue of AJOT. It can be found online and it will be open access. So everybody can read this work and help to use it to guide their practice. So thank you guys all so much, and we'll hopefully talk again soon. Bye.
Bye.